Good morning, everybody. Today we will discuss acute suppurative otitis media. This is an acute condition in which there is pyogenic infection of the middle ear cleft, which include eustachian tube, middle ear, and antrum and mastoidea cells. So in middle ear, there is attic, antrum, mesotympanum, hypotympanum. So infection of all these parts by a bacteria, that is a pyogenic inflammation, is called acute suppurative otitis media. So what is the route of infection in these patients? The route of infection is, it can be ascending infection from eustachian tube. That is, the infection in the middle ear usually reaches through eustachian tube. Reflux from nasopharynx into the middle ear occurs during the swallowing, nasal blowing, closed nasal swallowing. This is closed nasal swallowing is a known as Toynbee maneuver. It is the result of negative pressure in the middle ear, that is sniffing. This all lead to ascent of infection from nasopharynx to the middle ear cleft or in middle ear proper. So primary requirement is infection in nasopharynx tube. So the cases which can be presented as one, first anatomical obstruction, that is big adenoids, nasopharyngeal tumor. This obstruction lead to stasis and infection of the nasal cavity, which act as a source to ascend from eustachian tube. Second, infection, adenoiditis, tonsillitis, rhinitis, sinusitis, pharyngitis. So these all are source of infection or reservoir of bacteria in nasopharynx which ascend in middle ear cleft. Forceful blowing of nose, the forceful blowing of nose can push the infection to the through the eustachian tube to the middle ear cleft. Swimming, during diving, the water enters the nose under pressure. If the water is infected, it can spread the infection to the nose, sinusoid, sinuses, and middle ear proper. Iatrogenic is the post-nasal packing after adenoidectomy. It can lead to ascent of infection as a foreign body. It can act as a reservoir for bacteria too. Feeding bottle. In supine position, feeding bottle may lead to ascent of the milk in the middle ear cavity via eustachian tube. Especially in children's, the eustachian tube is more horizontal and broad. So the ascending of infection from the nasopharynx is easy as compared to an adult, in which the eustachian tube is more oblique and has been developed. Now, pre-existing tympanic membrane perforation due to trauma while cleaning the extra-auditory canal, it can open and slap on the ear or past chronic suppurative otitis media. In past chronic suppurative otitis media, there can be acute exacerbation of the disease. So acute on chronic suppurative otitis. It can be called acute on chronic suppurative otitis media. Fracture of temporal bone in case of head injury, middle ear may be involved with the fracture of the temporal bone. So the bone infection can travel through the fracture of the bone. Then the third is the bone infection. It's a rare condition, but it can occur. So the infection which is already present in the bone, that is septicemia, it lead to development of infection in the middle ear cleft. The predisposing factors which are present in the patient that help in development of the infection, these are reduced immunity. Reduced immunity can be in malnutrition patients, poor dietary intake habits, micronutrient deficiency too. Too much physical and mental exertion, lack of rest and sleep, exposure to extremes of the climate and temperature can affect the overall resistance of the person's immunity, and infection can occur easily. Barotrauma. Atmospheric pressure changes, especially during the flying and deep water diving, which can affect the eustachian tube. Also, this change in pressure can lead to ascent of infection through eustachian tube. Exanthomatous fevers like measles, diphtheria, and whooping cough also cause acute otitis media, as they cause inflammation of the eustachian tube. Palatine disorder, cleft palate, palatine palsy, this all lead to opening of the lower nasopharynx, opening of the eustachian tube in nasopharynx, and this can lead to ascent of infection easily. Nasal allergy. So, in nasal allergy, there is increased secretion of the mucus in the nasal cavity, which in turn can ascend through eustachian tube containing bacteria. Through eustachian tube containing bacteria. Now, the positive organism, the most common organism which is present is Staphylococcus pneumoniae, followed by Haemophilus influenza and Moraxella catarrhales. Other common are Streptococcus pyogenes, Streptococcus aureus. The uncommon are the gram-negative bacilli, that is from skin. But in cases of trauma, we can have those bacteria too in the infective culture. In some cases, no organism has been found. Stages of AS1. Stage of tubal occlusion. This is the condition when there is edema and hyperemia in the nasopharynx and eustachian tube gets occluded. This leads to absorption of air in the middle ear cleft and creation of the negative pressure in middle ear cavity. So, there is negative pressure in middle ear cleft. The patient will complain of mild deafness, ear fullness, and ear pain, but there will be no fever as there is no acute infection in this stage. The signs will be retracted tympanic membrane on audiological findings include relatively shortening of the handle of malleus, horizontal position of handle of malleus, prominent of the lateral process, loss of light reflex, and conductive hearing loss. Loss of light reflex is the first sign which we will get when there is retraction of the tympanic membrane or negative pressure in the tympanic membrane. Second is stage of presuppuration. As the name suggests, stage of presuppuration, in this there is infection of the pyogenic organism into the middle ear cavity, such as results in mucosal hyperemia. Also, inflammatory exudates appear in the middle ear proper. Always remember, the infection occurs due to stasis of the secretion and they get infected by the bacteria. Now, the patient develops high-grade fever and is restless. There is bubbling sound in the ear. The patient will complain of fullness of the ears, and the child, usually the childs are affected, so child does not get the attention due to if not get proper attention to this, then the patient will develop severe ache. Now on later, this on examination, that the signs have the past tense of or the tympanic membrane is congested and is bulging. You can have a cartwheel appearance, that is, there is vasodilation on the tympanic membrane. Appearance of this vessel will be like cartwheel, leash of blood vessels along the handle of malleus at the periphery of the tympanic membrane. So, the tympanic membrane will be appearing like cartwheel and the spokes are made up of the blood vessels which are reddish in color. As the contour of the tympanic membrane is affected, So there will be loss of the light reflex. Now later on the complete implementation include flaccida get uniformly congested and red in later stages. Here also we will get uh, conductive type of hearing loss. The third stage is the stage of suppuration. In this stage, there is formation of the pus in the middle ear cavity. So when also there will be collection of the pus in mastoid cell, the tympanic membrane start to bulge. So here now the patient will complain of excruciating pain, severe pain, increased deafness. Patient will develop fever, high grade fever. Um, Patient may develop vomiting, diarrhea, even convulsions can occur. So what all things will be present on examination? The tympanic membrane will appear red, bulging, and we can have a point where it can get rupture, or we can have a pus point on it that is about to get ruptured. Handle of Malleus is encurved in the swelling and the TM will be protruded. Here again, the curvature is affected. So light reflex will be absent. As I told you, a pus point or a yellow spot on the TM where rupture is imminent, a nipple-like protrusion from the tympanic membrane with a yellow spot on the summit. So it can get rupture anytime. Tenderness all over the mastoid antrum region, suprameatal triangle. Also mastoiditis, clouding of air cells on X-ray is seen. Now, if the treatment is not given, then there will be perforation and the pus will flow out and the pain will subside, the fever will subside. But for that, this is known as a stage of resolution because all the signs, the symptoms of the patient subsides when this stage starts. So the TM ruptures due to pressure necrosis, as I've told you, a yellow point is formed. That yellow point that lead to rupture of the tympanic membrane and all the discharge collected in the middle ear cave comes to the perforation. So this result in otorrhea and the symptoms which the patient is getting, like severe ache, like fever and fullness of ear and decreased in, they start to get subside. But the inflammatory process is still there. So as the infective material or the infective load gets decreased, the inflammatory process start to resolve. So the complaint in this stage will be otorrhea, that is discharge from here. It can be blood tingled initially, then later on the stage it may become mucopurulent. In the pain, the fever, it gets subside. On examination, the external auditory canal is filled with discharge, which can be blood tinged or it can be mucopurulent depending upon the time duration. Now we will get pulsatile sign, pulsation in the ear discharge. It is called lighthouse sign because as we have seen in previous stages, the middle ear cleft is involved. There will be pulsation because the discharge is coming out under pressure. So it, there is movement of the discharge with each heartbeat. So it appears like a lighthouse. So it's known as lighthouse sign. The perforation of the pars tensa usually is anterior-inferior, is usually in anterior-inferior quadrant. Now, stage of complication. If the patient is not treated as the symptoms have been resolved and does not get treated, then the patient can go in the stage of complication. In majority of children, acute otitis media itself is a self-limiting condition, responds well to medical treatment, but if the virulence of the organism is high and resistance of the child is poor, the infection may spread beyond the middle ear space. So the complication usually occurs in second and third week, constituting the infection. Signs and symptoms may reappear. So proper treatment, if it is not given, the patient is immunocompromised or have a high virulent organism, the patient can go in stage of complication. What all investigation we need to do in cases of acute suppurative otitis? First of all, the testing of hearing to show that the proper conductive hearing loss is there. Then we will do culture test for the bacteria to acknowledge what is the infective organism and to which antibiotic it is most sensitive. So we can change the regime of the antibiotic according to the bacteria. Then the third is CT temporal bone. It is indicated in only cases of refractory mastoiditis. There is clouding of air cells because of exudate and the pressure necrosis leads to formation of coalescent mastoiditis may be seen. Demineralization of air mastoid mastoid air cell septa is the key radiographic sign of a mastoid osteitis. So the line of the treatment of acute suppurative otitis media is if the patient is simple without complication, the first line of treatment is amoxicillin. The patient's symptoms resolve in 2 to 3 days. We will continue the antibiotic for the full course. Then after 4 to 6 weeks, we will ask the patient to come again and check for the signs and symptoms. If it is resolved completely, the patient is safe to go. If there is medial ear infusion, then we will need to treat the effusion. If it is mucopurulent or it is purulent or it is mucoid or serous, depending on the condition, we have to start the treatment. If it's serous and the tympanic membrane is not ruptured or recovered completely, we may need to insert bromide. But if it is suppurative or mucopurulent, we need to give antibiotic and again follow the procedure. Like if the symptoms do not resolve after 2 to 3 days, then second line of antibiotics, that is amoxicillin with clavulanic acid or cephalosporin is given. Then again, if symptoms are relieved in 2 to 3 days, we will ask the patient to come after 4 to 6 weeks. Again, check for effusion. If the relief, there is no need to follow up. If effusion is present, we need to treat the effusion. If the discharge is not resolved, even on the giving of the second line of drugs, then we will go for tympanocentesis, that is aspiration of the pus from the cave, middle ear cleft, and we will send the pus for the culture and sensitivity, and we will start the antibiotic as per the culture sensitivity. Again, we will send for all the patient after 4 to 6 weeks, and we again assist for the middle ear effusion. Now, the condition when there is complications. So, we will look for toxic shock or septic loop if it is newborn, immunocompromised patient, or extracranial or intracranial complication like labyrinthitis, facial paralysis, and meninges. We will go directly for the culture and sensitivity of the pus and will start the antibiotic according to the culture reports. Also, we will start second line of treatment, that is amoxicillin, clavulanic acid or cephalosporin as soon as the patient comes to the OPD. Also remember, we will need to get the patient admitted and start for the treatment of the complications too. Like for facial paralysis, we need to give multivitamin as well as uh, steroid to decrease the inflammation and improve the facial outcome. Similarly, in labyrinthitis, we need to give vestibular sedative to resolve the vertigo. In meningitis, we need to give antibiotic which can cross blood-brain barrier. Along with that, if the patient is complaining of raised ICT or having a symptom of raised ICT like blurring of vision, headache, we may need to give mannitol or osmotic diuretic, also steroid along with carbonic anhydrase inhibitor to resolve the raised ICT along with resolving of the infection of the meninges. So, what is the doses? That is for ampicillin, it's 50 milligram per kg per day in 4 divided dose. Similarly, amoxicillin, it is 40 kg per kg per day in 3 divided dose. Along with that, we need supportive treatment. As we know, the source of infection is generally present in the nasopharynx. So, nasal decongestion is also a supportive treatment for the decreasing the chances of infection in or proper drainage of the middle ear cleft. So ephedrine 1% in adult and 0.5% in children's. Oxymetazoline and xylometazoline drops are also available in market that act as a nasal decongestant. Also remember oral decongestant, that is pseudoephedrine 30 milligram twice daily can also be given. So this all will reduce the inflammation or uh, congestion in the nasal cavity, ultimately leading to clearing up of the infection in the nasal cavity and nasopharynx. So the source of infection get resolved. Also, as we will give the treatment symptomatically, like if the patient is having severe pain, we will give analgesic. If the patient is having high grade fever, we will give antipyretic, that is paracetamol and NSAIDs. Then comes the treatment of the ear. The patient complain of ear fullness or discharge from the no ear. Then we will need to have clean the ear of the discharge and make the ear dry. Now we can also apply local heat over the, that is applying a warm cloth over the part around the ear or some what hot air bag to relieve the water bottles, hot water bottles to relieve the pain in the local area. Also remember, in cases of stage of pre-suppuration and stage of suppuration, when the tympanic membrane is intact, we may also go for laryngotomy, in which we make an incision over the most prominent part, that is the yellow dimple made naturally, so that the discharge which has been collected in the nasal cavity, sorry, in the middle ear cavity, it comes out and the patient get relieved. So the bulk or the infection bulk in the middle ear is get reduced and the patient can get resolved. Thank you for the listening to the uh, topic. This was all for today. Thank you.